Good morning. We'll start the Masterclass. We have three excellent speakers in this session. So let me invite Dr. Mark Puhendran to speak on advances in diagnosis and management of upper limb cancers.
Thank you, Mr. Chairman, and good morning, everybody. Thank you for being here on the last day, morning of the conference. I'd like to thank the organizers for giving me this topic on the, which is something that I see quite often in my practice. Now, when we talk about cancers of the upper extremity, we're talking about malignant tumors. And the upper extremity, they basically arise from multiple sites. You can have skin cancers, soft tissue cancers, and bone malignancies. But in addition to that, something that we don't talk about very often are the hematopoietic malignancies like lymphoma. They can be primary or metastatic, and the treatment philosophy in either setting would be different. For example, this is a patient with melanoma arising the subungual region, a primary, which we would treat surgically. Whereas this patient actually has a soft tissue metastasis from melanoma, and the treatment approach would be different. So I would just like to change gears a little bit, talk about the journey that the patient goes through, or their cancer journey. Now, there's initial presentation when the patient actually first comes to see us. Sometimes this is actually much later down the road in their disease. Some of us are fortunate enough to see the patients a little bit earlier. Then we try to make a diagnosis, and we do this using laboratory investigations, imaging investigations, and most of the times we still need tissue diagnosis in order to make that diagnosis. Then we stage the patient, then after that we start treatment. Now, treatment can either be curative or non-curative, depending on the stage of disease. And there are now about 4 accepted modalities for treatment of cancer: surgery, which we are the ones who do, chemotherapy, radiotherapy, and immunotherapy. So there are all these options available to us, and it depends on the cancer that we are treating and the stage of for the patient. So moving on straight away to the recent advances, and there's actually been a lot, and I hope I won't confuse you as I go through them. Now, first of all, in the process of diagnosis, when we are trying to make a diagnosis, and this is where molecular pathology and looking at the basic molecular changes that happen at cellular level have actually come in and been established for maybe more than a decade, such that now in the latest WHO classification, we actually still having new entities being described on the basis of new molecular changes and immunohistochemistry changes that we see. So the advances that we see actually in better diagnosis and subclassification of tumors. Now, the next thing is in the area of imaging. We've had some sessions where we talk of new imaging modalities, especially in nuclear medicine scans, where we have different radioisotopes that are being created and tested. And also, again, we've had some topics on artificial intelligence that we had. This is definitely augmenting our ability to make a diagnosis. These are just some of my colleagues who've used it in the area of MRI diagnosis for spinal stenosis. These same colleagues I'm working with to actually use AI to try and augment our ability to diagnose sarcomas, because we all know when the radiologist gets it wrong, and that actually leads to mistakes that we make clinically. Radiotherapy, let's talk about treatment. Conformal radiotherapy, where radiotherapy beams are actually targeted and concentrated at the site of disease, and we minimize the collateral scatter, which is what causes collateral damage. These are getting better and better. This is just an example of IMRT and how we actually plan radiotherapy together with our radiation oncology colleagues, so that we can actually spare things like our perforators, spare the lymphatics where possible, spare the vessels, spare the nerves. We've gone to the level of being able to tell them, look, I actually see this vessel going to the flap that I'm intending to use. Can you avoid this so that deliver your radiotherapy in a different way? And that has helped in some cases. In addition to that, some of us are lucky enough to have proton therapy, which is particle radiotherapy. The Japanese have heavier ions, but this also helps to minimize the collateral damage that's caused from radiotherapy and just deliver it to the cancer at the intended target. How about surgery? What we do? 3D printed models and cutting jigs are quite widely used now, and they will continue to help us do more accurate surgery and make it easier for us to do the surgery. Computer navigation has been around for more than a decade. It helps us, especially in areas like the pelvis, maybe not so much in the upper extremity, but definitely in areas like the pelvis where the anatomy can be confusing. It just helps you guide where your cut where you think you're supposed to be cutting. Robotic surgery, as some of our colleagues had presented earlier, again, we are slowly getting used to using it in the upper extremity, but definitely a lot more in the abdomen and pelvis. And finally, another thing that one of my colleagues, Dr. Gao Yixia, is working on, mixed reality, to augment our surgery, where you can actually mesh the imaging onto the patient that you are operating on. It's not really for prime time yet. The times that I've tried it, I got a headache because it's still hard to actually integrate mentally what you're seeing from the scan with what you're seeing on the patient. But we expect this technology to get better, and this may come and affect our clinical practice and surgery in the near future. Now, this is where it's all exploded. We now very much understand the molecular mechanisms behind cancer much better. All the steps, or more like a lot of the steps that lead a normal cell to become a cancer cell and how cancer develops. And that's why we've been able to do targeted therapy. Of course, there's a lot of hype that comes along with this, and you can see in this Times article, the war against cancer, these are the bullets and the ammunition. The good thing is we've actually identified a lot of targets that we can hit, and this targeted therapy has made a significant difference in some cancers. It started with actually a sarcoma, GI stromal tumor, but now things like lung cancer. The survival times for patients with EGFR positive metastatic lung cancer are so different from what they used to be just a decade ago. The immune system, everybody talks about immunotherapy now. And we also now better understand the immune cycle and how cancer actually interacts with our immune system. What's very widely used is now what we call checkpoint inhibitors, where we actually remove the blocks on the immune system so that they can go after the cancers. And it's been shown to be very useful in some cancers like melanoma, which appears and we treat in the upper extremity. There are even better, newer things that are coming on the horizon, things like bispecifics, which are targeted, which actually are antigens, molecules that have two antigens that can bind two molecules together so that you can target both of them. And also something that, again, you may read about in newspapers, CAR T cells, where we actually harvest the patient's T cells, modify them in the lab, and reinfuse them into the patient to attack and treat the cancers. This is something that actually just some of my colleagues that I work with actually just published this month or last month in Nature Medicine, and it was actually featured in the newspaper just 2 days ago, where they've actually had patients who had refractory leukemias, T-cell leukemias, that they treated and had basically failed multiple lines of treatment and had 10% survival chance. I think they had about a 15 out of 17 salvage rate, which was pretty good for patients who didn't have much of a chance. Now, these are the articles, these are the things we like to talk about, these are things that make it to the press and the media. And you know, it sounds very nice and glamorous, but I mean, I'm particularly happy for them because I know the pain they went through. These are the people that I work with, and these are the people who call me when some of the patients who are going through this treatment actually run into complications. It's not without trouble, and they soldiered through and they managed to find something that actually works. So it's what we need to do for research. It does make a difference, but the process is difficult. In the research realm, we're now trying to understand the environment that the cancer lives in, what's happening around it, the tissue around it, how it interacts with the immune system at the cellular level, because once we understand that, then we can hit the cancers even better. So this is what the research is going into right now, and this will influence how we treat patients. Now, how does it all come together? In the past, we used to have basically a one-size-fits-all. This is a patient with X cancer, for example, osteosarcoma. We give them the standard treatment, cisplatin, doxorubicin, methotrexate. We know that we have a 70% survival rate. There'll be some non-responders where the cancer practically laughs at your preoperative chemotherapy. You have responders that do well, and then you have those that develop adverse events like cardiotoxicity. Nowadays, as we understand with the benefit of new diagnostics, we're able to actually have more treatment options available. And this is just another example, one of our patients who had a young patient with a metastatic inflammatory myofibroblastic tumor. We were at our wit's end and we thought we were going to lose the patient very quickly. We sequenced the patient, found a targetable mutation, basically treated the patient with ceritinib, and thankfully the patient responded. He's surviving, he's alive with disease, went on to open a Korean food restaurant. But you see, what we worry about in our hearts is, how long is this response going to continue? And when is it going to become resistant? When's the cancer going to outsmart us and then become resistant to this, and then we've got no more tricks in our tool bag, basically? What we're trying to do now is to move from precision medicine actually into personalized medicine, where instead of looking at all these mutations for each cancer, we actually go to the patient, we study the patient, the cancer, we study the cancer also, and we understand all the different parameters within the cancer itself, and then we treat the patient. So that means the treatment is individualized, not based on some trial that was done where you have 70% responders. Straight up front, we sequence everything and we go and treat the patient. Now, this is of course a controversial approach because what data you have to actually back this approach? In our hearts, we know that this may make sense, but there isn't actually, you don't have the benefit of prospective randomized double-blinded trials to guide your treatment. So again, something that my colleagues are looking at, this is Dr. Valerie Young from the National Cancer Center across the expressway from us, and this is where we actually we do work closely with them, because if we don't, we just can't do this kind of work. Of course, AI. We're able to get so much information about both patient and cancer now. How do we put it all together? And definitely this is one thing where AI can help us actually integrate the information so that we can come up with personalized treatment for each patient. But with all this and all that I've said so far, and I hope I haven't confused you, just want to take a quick pause here. Because actually sometimes the elephant in the room is this, where the patients don't come and see us early. They come and see us late. Sometimes it may be an issue of access, where the patient can't come and see us or can't afford to come and see us. Or sometimes, I mean, this happened in Singapore. It's not that we're not accessible, but the patient was just scared and waited till it was too late. Normally it's 12 midnight when the patient's bleeding. That they come to the emergency room and this is what you see, and this is the photo that my registrar actually sent to me. We know that no matter what, the more advanced your cancer is, you can throw everything you want at it, your treatment outcomes are still poorer. We're getting better at treating patients with metastatic disease, but we don't win the war. We may be able to get them to survive longer, but the patient will probably still pass on because of the cancers. This is just the example of sarcomas and the size of the tumors and the prognosis. I know this is from 2002, but if you fast forward it another 22 years till now, it hasn't really changed that much. If you come in with a high-grade tumor that's more than 10 cm in size, your prognosis is very bad. You come in with metastatic disease, it's still very bad. We haven't really moved that needle very well. So actually, things like access, coming to see us on time early actually make a big difference. Next, we talk about targeted therapy, but is this therapy actually well tolerated? Just as an example, the cost. Who can really afford this $7,000 a month for the next 3 years? It's hard in Singapore, and I'm quite sure it's hard in many countries around the world. And it's not like we don't talk about the side effects that the patients also get. Now, the thing is this. When we see a patient coming in with a sarcoma that's fungating, we know what needs to be done. And we resect it, we reconstruct, we flap, and we cover. We do this very well. And we've been doing this for many years already. This is a patient with Ewing sarcoma, the humerus that was treated by Professor Fo 20 years ago. What's actually important, sometimes we forget about how important it is to actually continue doing what we do well and stop focusing on the fancy stuff. Just make sure that our systems are going well. One example, patient with large squamous cell carcinoma of the hand. If this was left to a surgeon alone, we probably need to do a partial amputation. At worst, we can spare the thumb. But then what do? We just give radiotherapy, and this was the result 6 months later. disease under control, patient still has their hand that they are able to use. So this is where working in a team with all the other disciplines actually makes a big difference, and it's a big help, and we shouldn't forget that. So if I could just summarize, when we talk about advances in cancer and upper extremity cancer, there's a sea of change, and it's happening very, very quickly. It's difficult for a single individual to actually keep track and keep up with all these changes. There'll be a lot of nice stories, and it gets disseminated quickly thanks to social media and the press. But we do have to worry, and we do know that there are issues with the cost of treatment, and we worry. I mean, you can treat one patient in one drug in a certain country, good result, but it's not really fair if you can't afford the same drug in another country. And while it's nice to have these advances, it's actually better to come up with earlier diagnosis and to treat them appropriately. We can get this so that we can achieve this by actually giving better patient access, better education, better awareness, get up our screening programs, make sure they come for them. And then we also need to teach our colleagues, because sometimes if our own colleagues are not aware of the treatment that's required, the patients may not get the appropriate treatment even when they come. So with that, I thank you very much for your attention.
Thanks, Mark Edward. That was a good overview of the recent advances on the concepts of good cancer treatment. Now it's open for discussions. Any questions?
Mark has to catch a flight, but do you have time for a question?
Oh yes, definitely. Sorry.
Yeah, 2 or 3 questions quickly for Mark before he leaves us.
Mark, one question. How did you decide in that hand with squamous cell carcinoma not to operate?
I guess the first thing was that we need to prove there was a squamous cell carcinoma, and we also know that the local control rates for squamous cell carcinoma are almost as good through radiotherapy and with surgery. It's a little bit better surgery. So in view of this situation where the treatment, the surgical option was very drastic, we actually just discussed it at our tumor board with our radiation oncology colleague and said, we'll take this. So it's first knowing what treatment modalities are available, and then secondly, we are lucky we have a tumor board, so we just discussed it with our colleagues and they said, we'll take this one.
That was a wonderful presentation. Now, we see often tumors involving the brachial plexus. And if the FNAC has come out as a sarcoma, what would be your line of thinking?
Okay, I'll answer this quickly, but you actually have the expert sitting there as the chairman, because he gave a talk on it. So I guess if it's a sarcoma involving the brachial plexus, it will depend on the location and depend on what the final diagnosis is. There'll be either a low-grade sarcoma, which actually with core biopsy is hard to diagnose. So I assume this would be a high-grade, probably an MPNST, which is the most common. What I would do would be to give preoperative radiotherapy in the, to actually, you may not necessarily shrink the tumor, but at least you control it. And then I'll do, as far as possible, wide resection. Now we know that that's a nice theory, because wide resection of the brachial plexus means you are basically paralyzing the patient. However, so I think that's the official answer, but we all know those of us who operate around the brachial plexus know that it's actually hard to get a wide resection. But that's actually why I would throw my radiotherapy up front first, because you throw the whole kitchen sink at it, you can't go back. And you just give it your best shot. Nobody likes operating in a radiated field. How you deliver your radiotherapy, whether you want to give short burst radiotherapy and then go in like the week after, I think that's what we may be moving towards, so that you don't have all the fibrosis and inflammatory effects of the radiotherapy, because it's just hard around the brachial plexus to do that. So that would be my short answer.
Thank you.
Thank you. Thank you. Now we'll go on to the second masterclass. It's double free muscle transfer, addressing total brachial plexus injury. Dr. Hattori, I think yesterday he has given us some insights into his double muscle transfer. I think we'll have more details today.
Good morning, everyone. I'm Dr. Hattori from Ogori Daiichi General Hospital in Japan. Chairman, thank you very much. I'd like to share our experience for reconstruction of total brachial plexus injury with double muscle transfer. My mentor, Dr. Doi, developed double free muscle transfer and firstly reported its technique in a hallmark article in 1995. Now this technique is well known as DFMT and Doi procedure. Scope of my talk include surgical technique, recent modifications, long-term results, and future of double muscle transfer for reconstruction of total BPI. From 1990, 157 patients underwent double muscle transfer in our hospital. Among them, 124 patients were followed for longer than 2 years. Age of patients was median 24 years. Interval from injury to first free muscle transfer was median 3.5 months. Follow-up period was median 34 months. First, I'd like to talk about surgical technique of double muscle transfer briefly. First free muscle is transferred for reconstruction of elbow flexion and finger extension. Gracilis is nourished by thoracoacromial artery and thoracic vein and is neurotized by spinal accessory nerve. 2 or 3 months after first muscle transfer, second free muscle is transferred for reconstruction of finger flexion. Gracilis is nourished by thoracodorsal artery and vein and is neurotized by 5th and 6th intercostal nerves. Concurrently with first free muscle transfer, shoulder function is reconstructed too. When proximal stump of C5 or C6 is available for nerve repair, nerve graft is performed for reconstruction of suprascapular nerve. When C5 stump is not available, contralateral C7 or phrenic nerve is transferred to suprascapular nerve. Similarly, intercostal nerves are transferred to biceps triceps branch of radial nerve for elbow extension reconstruction in conjunction with second free muscle transfer. Also, sensory branches of intercostal nerve are transferred to median nerve for sensory reconstruction of the hand. Secondary procedures are very important to improve finger function after double muscle transfer. These procedures are mainly for stabilization of shoulder and wrist and for correction of intrinsic minus deformity of fingers. Glenohumeral arthrodesis was performed in 6 patients. When upper trapezius is functioning, this surgery can achieve not only for shoulder stabilization, but also shoulder abduction motion through intact scapulothoracic joint. In double muscle transfer, instability of wrist is problematic in most patients. Wrist arthrodesis is frequently performed to stabilize the wrist and improve finger function. Intrinsic minus deformity of finger is frequently encountered. Correction of this deformity improves the finger function considerably. In the patients on left, PIP joint arthrodesis was performed following double muscle transfer. After PIP joint arthrodesis, finger motion was possible only at MP joint. In patients on right, MP joint boral capsulodesis was performed to correct intrinsic minus deformity. After MP joint boral capsulodesis, finger motion was done through mainly PIP and DIP joint motion. These surgeries are performed depending on stiffness of finger joints, balance of strength between finger extensors and flexors, and patient's needs. I'd like to show a typical case with intrinsic minus deformity following double muscle transfer. This patient underwent double muscle transfer and achieved strong recovery of transferred muscle. However, he presents with typical intrinsic minus deformity. When the MP joints are stabilized in flexion position using orthosis, fingers motion dramatically improved. This patient is a very good candidate for wrist arthrodesis and MP joints volar capsule death, and will undergo these surgery in near future. This patient who underwent double muscle transfer achieved excellent finger function. However, inability of shoulder external rotation makes it difficult to move the reconstructed hand in space. Moreover, it is difficult to hold the objects with a hook grip due to a pronated position of the forearm. In double muscle transfer, first free muscle acts as forearm pronator, and second free muscle acts as a shoulder internal rotator and shoulder adductor due to the position of the transferred muscles. Because of these drawbacks, difficulty of shoulder external rotation and pronated position of forearm restricts the use of reconstructed hand in daily activity. We have recognized the importance of reconstruction of shoulder external rotation and forearm supination after double muscle transfer. Recently, we frequently perform radio-ulnar fusion in addition to wrist arthrodesis to obtain supinated position of forearm. In 2013, we have reported contralateral lower trapezius transfer. Contralateral lower trapezius with lumbar fascia is transferred to infraspinatus. This procedure is useful to reconstruct shoulder external rotation after double muscle transfer. This patient underwent contralateral lower trapezius transfer for reconstruction of shoulder external rotation after a double muscle transfer. This is a preoperative function of shoulder external rotation. 8 months after contralateral lower trapezius transfer, he achieved good shoulder external rotation. I would like to show the long-term results of double muscle transfer. The results of shoulder function, which was provided by suprascapular nerve repair using C5 root, contralateral C7, or phrenic nerve transfer are shown. Phrenic nerve transfer provided better range of shoulder abduction than contralateral C7. There was no difference in shoulder arc rotation between 3 procedures. Range of active flexion was median 115 degrees. Power of elbow flexion was 13% of uninvolved healthy side by Kincom and 16% by HHD. Results of elbow extension are shown. M3 strength was achieved in 26% of patients, M2 in 37%, and M1 in 26%. More than M2 strength of elbow extension was enough to stabilize the elbow, while transferred muscles were moving the finger. 63% of patients obtained more than M2 elbow extension. Total active motion fingers was median 44 degrees. 31% of patients achieved more than 60 degrees of turn, which was ranked as excellent. 78% achieved more than 30 degrees of turn, which was assessed as satisfactory recovery. However, 22% could not obtain satisfactory finger function. Sensory recovery of the hand is also very important for finger function. 22% of patients obtained S2 protective sensation in median nerve territory of the hand. 48% restored S1 deep sensation. However, 30% did not have any sensation of the hand. This is a result of questionnaire to the patients regarding the use of reconstructed hand in daily activity. 20% of patients always use the hand, and 21% sometimes use the hand. However, 29% of patients never use the reconstructed hand in daily activity. I'd like to present summary of recent case. This patient underwent double muscle transfer, suprascapular nerve repair with C-hive root, wrist arthrodesis, and PIP arthrodesis. Clinical outcome 7 years after surgery are shown in the movie. He underwent suprascapular nerve repair with C-hive root and achieved very excellent shoulder function. He obtained full range of active elbow flexion. However, elbow extension was restricted due to elbow joint contracture. He achieved strong grip. Because he underwent PIP arthrodesis, the motion was possible at only MP joint. He can well control shoulder and elbow. He has no difficulty in dressing change. Surprisingly, he can jog without any support to the involved upper extremity. This patient underwent a double muscle transfer, phrenic nerve transfer to suprascapular nerve, wrist arthrodesis, MP joints volar capsulodesis, and radio-ulnar fusion. Clinical outcome 7 years after surgery are shown. Suprascapular nerve is well recovered. However, shoulder function is not satisfactory. As I have already mentioned, second free muscle, which was reinnervated by intercostal nerve, acts as shoulder adductor and internal rotator. This becomes an antagonist function against suprascapular nerve. This is the drawback of double muscle transfer in terms of shoulder reconstruction. He achieved strong hook grip. This is a 4 kg weight iron. He can lift 4 kg iron with his left reconstructed hand. He always uses his left hand for daily activities, such as carrying a shopping bag. In summary, I'd like to talk about current status and future of double muscle transfer. This technique is a reliable procedure to restore hook grip in total BPI. However, there are some problems to solve. Double muscle transfer needs too long and complicated microsurgery and long-term rehabilitation. However, not all patients undergoing this surgery use the hand in daily activities. The solutions are strict indication for surgery and modification of surgical procedures. Elderly patients and high BMI is a worst prognosis factor for this technique. Thus, such patients are not good candidates for double muscle transfer. Recently, we focus on importance of secondary reconstruct procedures to improve finger function. In addition to stabilization of shoulder and wrist and correction of intrinsic minus deformity, reconstruction of forearm supination and shoulder external rotation are also very important to improve finger function and should be reconstructed. Thank you for your attention.
Thank you, Professor Hattori. Any questions to Dr. Hattori from the floor? Dr. Hattori, if I may, now there are nerve solutions for like the Wong procedure of contralateral C7 for providing finger flexion. So in this situation, when you have a patient presenting to you early, what is still your preferred procedure, the double free muscle transfer, or would you consider a nerve surgery before that?
We always consider the free muscle transfer if we reconstruct the finger function in fresh cases.
Okay.
When we are using a contralateral C7 as the nerve, donor nerve, how do you know that you are getting the motor fascicles to that particular nerve? It is going to be big, the contralateral C7. Your nerve, obturator nerve is very small if you're using the gracilis. How will you coapt, how will you decide where to attach that nerve?
So we always use the contra C7, only posterior division of contra C7, not the whole contra C7. So it is always not so big.
And the posterior division is going to contain more of motor fibers.
Yes.
So you are comfortable with that. Thank you.
In your talk, you showed usage of both phrenic as well as the intercostals. So what is your long-term experience in such patients?
Phrenic nerve transfer?
Yeah, phrenic along with the intercostals.
You mean the respiratory function?
Yeah.
Usually, after phrenic nerve transfer, our experience, percent of VC is decreased 15% or 20%, but they have no symptom for respiratory dysfunction. But however, when the patients, become older, so we don't know the risk.
You showed your 34-year experience, so that's what I'm asking, the long-term experience.
Long-term result of phrenic nerve transfer?
Phrenic and intercostal combined, yes.
No problem.
Thank you.
If there are no more questions, we'll go on to the next masterclass, the sensation of touch and the real functions of the hand. Dr. Anthony.
Thank you very much. This is going to be the most unusual presentation for the conference because there's absolutely no science involved. There are no conclusions, but hopefully it'll give you something to think about. I'm not a psychiatrist or psychologist, so this is all just fairly amateurish. So assessing the hand function, we as hand surgeons love measuring things. We measure to determine pre and post-op assessments, comparing different treatment modalities, to assess the extent of an injury and to assess the level of impairment or disability for compensation claims. So we measure physical things, impairment. That is, we measure sensation, which is often limited to just two-point discrimination or maybe monofilament testing. We measure the motion of joints, the stability of joints, the strength, and all of these we then look up various tables like the American Medical Association guidelines and we come up with a percentage impairment. But that doesn't take into account the impact of that impairment. So now we look more at disability. That is, what is the functional loss due to a given impairment? And now we get into patient-rated outcome measures, and there are many different types. Most of those, however, question pain and the ability to do physical things, but only a few briefly assess the general impact on that person of their injury. And if the function is not listed on that PROM, then it's not assessed. So joint movement is easy, strength is easy, but what about the assessment of sensation? So if we look at the skin, we have numerous sensory end organs, free end organs, discs, Krauss bulbs, root hairs, Meister corpuscles, and they all respond to stimulus in a different way. Meister corpuscles, Paxinian corpuscles give a brief stimulus and then they quieten down, and yet others give a more persisting signal. So sensation, when we measure it, we talk about maybe light touch, firm touch, movement, temperature, traction, two-point discrimination. These are specific sensors for specific stimuli, but there are no specific sensors for feeling clammy skin. There are no specific sensors for dipping a finger into a liquid. There's no sensors for a gentle caress. Excuse me. We know 1/3 of the cortical representation of our hand is, to the sensory cortex, is from the hand. So the hand provides the means to manipulate our environment and to collect information. The brain collates all that information, but puts it into the context. So the two basic touch systems, fast alpha beta, A beta, and slow C fibers. So the A beta fibers give a high spatial and temporal resolution, but the slow C fibers are more diffuse and they're more emotionally responsive. They respond most strongly to a caress at about 3 to 10 centimeters a second. And then once we get these stimuli, they're encoded and go through various pathways up to the sensory cortex where they're perceived. And the A beta fibers give you acute information, but the C fibers give you a more diffuse, perhaps pleasant sensation. And then the higher cortex areas of the brain process these information. So there's quite a lot more than just touch and two-point discrimination. So I like to separate sensation as the physical feeling resulting from something that happens to or comes into contact with the body. But touch is the facility by which external objects or forces are perceived through contact with the body, in particularly with the hands. So why is this distinction important? The experience of touch is a central interpretation of all the sensory inputs modified by context, past experience, anticipation and fear, etc. It's not measurable by any prom. The experience of touch is one of the more important functions of the hand. So I was going to do a little experiment, which may not be too easy, but if you'll put your hands on your knee, you feel your knee, you have sensations through the palm. And then, if you like to, whether you can or not, hold the hand in the person next to you. It's the same sensation. We get the same function, but it's a totally different emotional response. So a handshake may be dry and clammy, soft and rough, gentle or firm, timid or confident. So touch, more than sensation, is linked to emotion and feelings. So why are emotions called feelings and not sightings or hearings or smellings? The experience of touch is intrinsically emotional. I'm touched by your concern. I didn't mean to hurt your feelings. You're prickly, it's rough. It's a sticky situation. He rubs me the wrong way. All related to the sensation of touch. People gently touched by a waiter in a restaurant tend to leave larger tips. Doctors who touch their patients are seen to be more caring and their patients may have better outcomes. People holding a warm cup of coffee feel more positive about those around them. Authors and philosophers have talked about touch for years. If a soul may look and a body touch, which is the more blessed? Seeing is believing, but feeling is the truth. And Nabokov wrote, "It is strange that this tactile sense, which is so infinitely less precious to men than sight, becomes at critical moments our main, if not only, handle to reality." So again, touch is an incredibly emotional and important sensation. Now, all senses do have a central emotional contact. We look at something and it can look beautiful, ugly or shiny, but when we're measuring vision, we just go to the optometrist and they put some lenses in. Hearing, audiologists will measure hearing acuity, but in hearing you can hear sirens, soothing music, children playing, all with a different emotional response. Smell, same thing. You can smell perfume, sewage, dinner in the oven, all different smells, but there are no specific senses for any of those things, and certainly no specific senses for durian fruit. Taste. We know all of the normal taste sensations. You know when you're eating an orange or a lemon, but there are no senses for oranges or lemons. And the same thing with touch. We know we can touch objects and they can feel rough and smooth, but again, there are no senses for clammy skin, for fluid. There are no senses for a comforting touch or for reassurance. Now we know that touch, such as when hugging and holding hands, releases dopamine, which is called the happy chemical. This is not released when you're holding other things. It gives a warm, positive sense of feeling happiness. its absence is associated with negative thoughts and sadness. So early in my career, I did a lot of medical legal work, interviewing and examining patients with injuries to determine liability and compensation. So we measured everything, we did a functional assessment, we calculated an impairment, gave them a number, and they received some compensation. Hand injuries have obvious functional impacts: loss of prehension, dexterity, grip, and loss of measurable sensation. And that does have a significant impact on the daily activities, self-care, employment, and recreation. And most of these are measurable with standard impairment and PROM assessments. However, the psychological and social impact of a hand injury often goes far beyond those measurable actions. The lack of sensation or touch, and the ability to touch, rather than the physical loss resulting from the injury, can often make patients withdrawn, isolated, and depressed. Through my early medical legal experience, I slowly learnt about the important hand functions that are never assessed. I can't hold hands, I can't caress my partner, I can't no longer self-pleasure, I'm scared to touch anything or anyone. I hide my hand, I don't go out anymore, my hand feels cold, everything is painful. So what happens to a person when the sense of touch or the ability to touch is lost or compromised through injury? Now, with loss of vision can be easily replaced by touch. Loss of hearing can be replaced by hand movements. People born deaf and blind can still live rich lives with touch. And I would recommend you to look up some books written by Helen Keller, who was born both blind and deaf, and how she learned to communicate with touch. So what happens if we lose sensation, or the sensation is severely altered? Does this have an impact on the emotional perception of touch? Yes, it does in some people. And does this loss result in a disability that can be measured? And I think that's very rare. So in some patients, these concerns are far more important than the physical loss of function. They've lost the ability to touch. They feel more withdrawn, they're more depressed, they're less likely to participate in rehabilitation, less likely to attempt return to work programs, they're more at risk of chronic pain, and we know that pain and negative emotions are deeply entwined. So a few examples. In Romania, unfortunately, in the 80s and 90s, where any form of contraception was banned, there was a massive influx of babies into orphanages, and because of lack of staffing, there was no touch, apart from feeding, there was no other social interaction. Their growth was retarded, they resorted to compulsive rocking and other self-soothing behaviours. And if not corrected, that loss of touch led to lifelong disorders of mood, cognition, and self-control. And so we now know touch therapy and physically holding neonates in hospitals and neonatal intensive care units is now a standard part of the management for all neonates. It's interesting to ponder what might happen with no-touch philosophies at school and sport due to the fears of sexual predation that may lead to touch deprivation in our children. And this fear propagated onto their children may be to the detriment of society. We all know people that touch a lot. Are they generally happier people? What about the people who don't touch? Are they perhaps not as happy? So the sensation of touch can't be separated from its emotional context. What about these patients? All of these patients will have an impairment. They will have a disability. Will their PROM ratings and impairment measurements accurately reflect the whole impact of their injury on their lives? Consider these hand functions. They really define who we are. They are incredibly important for that person, but none of them are measurable. They define who we are and how we interact with others. All these hand functions involve touch and therefore an emotional response, but none of these functions are assessed by PROMs. So the ability to touch and be touched is, I think, the greatest function of the hand. And for many patients, its loss is the greatest disability. And this extends beyond the measurement of sensation. So this gentleman, as two examples, he functioned well for 25 years after this injury, worked as a police officer, and he said things were good, but his hand never felt right. This young chap had a very nasty injury, but the arm was replanted, some functional gracilis transfers. He had good recovery, shoulder, elbow and wrist function. His hand was stiff, but it was a good helper. He had no pain, he had poor sensation. And I worked with him through his recovery for a number of years and got to know him quite well. And despite all of his surgery, he did function reasonably well until he suicided about 3 years later. Perhaps he'd lost the sensation and the ability to touch. So, again, no conclusions, but have a think about the sensation of touch and how patients use their hands and how you use your hand for touch. It's very different to what we can measure. And if you want, these 2 books are really quite interesting to read. Thank you very much.
Thank you. Do we have any questions?
A lot to think about.
Can I have a question which may be a little outside the purview of this talk? We have these patients coming late with a median nerve injury, like much later than what we normally, do a nerve reconstruction. But as far as the loss of sensation is concerned regarding the median nerve, I think that's much more important. So how late do you think you can repair or graft the nerve to recover some amount of sensation?
I think any sensory recovery is good. I don't know how late you can do, but also I think in this sort of context, people with carpal tunnel, severe median nerve problems, they don't seem to have the same problems. I think the loss of touch is also linked to the physical deformities that go with that. It's a composite of the function, the loss of sensation, and the loss of the ability to touch a person. So median nerves, they may have otherwise good function, their fingers are moving. I think they can manage that and it's not quite the same impact. But the loss of touch in the context of a major trauma is, I think, very important but not measurable.
Yeah, I mean, patients do complain that, they cannot take the keys out of their pocket or take objects from the bags.
Yeah.
So,
but they are looked at in some proms, but caressing your partner and other things like that are not measurable, but they are a very important part of our hand function. And what I'm doing now, talking with my hands, is an important hand function that is never measured.
So you suggest nerve repair irrespective of the delay in the thing, at least to get some sensation for every patient? Normally at 18 months we go for a reconstructive procedures than the nerve repair.
Yes.
You suggest nerve repair for everybody irrespective of the more than 18 years, 2 years, to get some sensation based on your philosophy?
Yeah, I think any sensation is good. Yeah. Thank you.
So any questions anymore from this? Okay, thank you. Thank you. We have come to the end of this session. We had 3 very interesting. I think the last one was more philosophical. I think we need to relook at the sensation part of it and the emotions. I thank all the speakers and the organizers for giving us this opportunity to chair the session.
Thank you very much. It's a pleasure being here.
Thank you to our esteemed chairpersons and respective speakers for their valuable insights and guidance during this session. Thank you. I kindly request all the delegates to go have a short coffee break and be back by 10:30. By 10, sorry.